Thanks for being here today. My name is Anna Hicks, and I'm an internist and geriatrician, and I'm here today to talk to you about age-friendly nursing care. And I'm going to say I'm not an expert in nursing care. I am a physician. However, I have been part of a bigger team that focuses on age-friendly healthcare for the past 5 years in my role in Adventhealth Hendersonville. And I've been invited today to share some of that knowledge that we've learned over the years as this team has learned. So the objectives for today are to understand why age-friendly healthcare is important, to learn the 4 M's of age-friendly healthcare, and to learn concrete ways to incorporate the 4 M's into everyday nursing care. But to do that, we probably need to understand what age-friendly means. And so to give you the best scenario that I can say is that age-friendly means caring for adults 65 and older. A lot of times we think about this as geriatrics. So age-friendly is a newer term for the world of geriatrics. A lot of times we think, what do we call people 65 and older? What do they want to be called? Well, I'll tell you, they do not want to be called elderly. So just strike that word from your vocabulary. Some people say seniors. Speaking about seniors, we think about the silver tsunami. I prefer the term older adults, and that's the word I'll be using today during this presentation. Age-friendly healthcare practice is an incorporation of 3 things. It follows an essential set of evidence-based practices, it causes no harm, and it aligns with what matters to the older adult and their family caregivers. And like I said, this is a new system coming through America, and it's been developed by experts in the fields. And the Age-Friendly Health Systems Institute for Healthcare Improvement is one of the leaders in this, and I've cited their website so you can get more information from this presentation. There are 3 major factors impacting the care of older adults that have been recognized. Number 1, demography, which means the number of older adults is projected to double in the next 25 years. And in fact, already in your county, Flagler County, the number of older adults 65 and older is twice that of the general US population. So you're already serving a population that the rest of America expects that percentage to grow in their areas as well. It's here now. There's complexity. Approximately 80% of older adults have at least 1 chronic disease, and 77% have at least 2. And if you remember, chronic diseases are things like heart disease, lung disease, COPD, chronic kidney disease, cancer, dementia, diabetes, hypertension. There's a whole list that qualifies. So just keeping that in mind. Disproportionate harm. Older adults have higher rates of healthcare utilization as compared to other age groups, and they experience higher rates of healthcare-related harm, delay, and discoordination. If you think about it, you know, the age is 65, let's say to 100. That's a big range. That's 35 years of life, right? And so that's a very large population grouped into one group of older adults. I want to plug in here about ageism. And I think that ageism is one of the reasons that healthcare-related harm, delay, and discoordination happen for older adults. And I just want to recognize, as we look at diversity, equity, and inclusion, we're not always talking about ageism, but ageism is a widely accepted form of discrimination in America today. Many of us in America fear aging. We have misinterpretations and misperceptions about aging and about getting older, but not all older adults are frail or unhealthy. Because we work in healthcare, we're seeing a very certain population, those who are the frailest, those who have the hardest time with their medical conditions. We're not really seeing the healthy older adults, and that can give us a skewed version of what aging looks like. So I just wanted to tell you that your perception of aging really will affect the way that you as staff and as a human age, and that the better perception you have of it and the more positive perception you have it, the less complications you will probably have as you get older. So lean into aging. Who are we seeing in our healthcare system? So we're seeing those who are frail. So frailty is a geriatric syndrome affecting about 10% of older adults. So 90% of older adults, 65 and older, are not frail, which is the good news. We just see a disproportionate number of frail in the hospital and the emergency department. The gradient of severity of frailty varies, and people can live with mild to moderate frailty for years. And this is becoming more common as the population ages. So our health span, healthy years of living, is actually getting longer, not shorter, even though for us in healthcare, it may seem like everybody's sick all the time. That's not the case. With frailty comes an increased risk of falls, disability, and hospitalization. There's a higher risk of health deterioration and death than was expected based on chronological age itself. And then people with severe frailty are 5 times more likely to die in 1 year than older people without frailty. How do we know who's frail? So there's lots of scales out there, lots of frailty scales, but my favorite is the frail scale because it's easy. It's 5 things. It spells frail, and it gives you a good idea of prognostication. So this is also an EPIC. It can be a handy tool for case management or nursing as you're looking at the patient and knowing what their level of ability or disability is. The first component is fatigue, so F. How much time during the previous 4 weeks did you feel tired? And you score that. Resistance, do you have any difficulty walking up a flight of stairs or 10 steps without resting and without aids? Ambulation is, do you have any difficulty walking a block without resting or without aids? Illness, how many illnesses do you have out of a list of 11 chronic care illnesses? So again, the diabetes, hypertension, stroke, cancer, dementia, heart disease, COPD, chronic kidney disease. If you have 5 or more, you get a point for that. And then loss of weight. Have you had more than 5% of your body weight lost? And that can be in the past year or more. And looking at the frail scale, people who are robust and not frail score 0. And people who are pre-frail score 1 to 2. And if you're scoring 3 to 5 points on this scale, you are frail, and 4 or 5 is severely frail. And that's where you fall into that category of higher mortality rate in the next year. And that's important as we take care of patients to know. It can really play into a lot of things, especially decisions about treatments or procedures or medications even. So we talked about age-friendly and what it means. And now let's talk a little about the 4 M's of age-friendly. So about 6 years ago, American Hospital Association, Institute for Healthcare Improvement, Catholic Hospital Association, John Hartford Foundation, all got together with a common cause to make healthcare safer for older adults, to do the right care and provide evidence-based care for older adults. And so they reached out to geriatric experts around the country. And most of those people are within larger healthcare systems in university settings, because that's where the geriatricians hang out. I didn't know if you guys know this, but there's not a lot of geriatricians in America right now. Definitely not the number we need to treat the silver tsunami or the influx of older adult population. And so they said, okay, we don't have enough geriatricians to do the day-to-day work. How do we make this simple? We can get it out to everyone in the healthcare system. And they took all this expert advice, research, best practices, and boiled it down into the 4 M's. And the 4 M's are what matters, medication, mentation, and mobility. And this is just really easy to remember and understand. It's easy for our staff. It's easy for our patients, their caregivers, the community. When you're practicing and looking at these 4 M's in every patient visit, you can't help but be doing best geriatric practice. Just as we review this, here is something we can look at: key actions in hospital and emergency departments, because that's where we're focusing in this effort right now here in this healthcare system. Looking at assessment and acting on with each of the 4 M's. So for what matters, we're asking and documenting what matters. And then we're not doing that just to collect data. We're doing it to really align the care that we're providing at that moment in time with what matters. We're reviewing high-risk medication use, and we're either deprescribing or not starting prescriptions for those medicines while they're in our care. We're screening for delirium at least every 12 hours, and we'll talk about the CAM-4, which is an EPIC and is a great tool for this. And then once we're screening, we're orienting older adults who are at risk for delirium. We're checking on them. We're preventing their sleep interruptions, using non-medicine approaches to promote sleep, and using safer medicines for them while they're in our care. We're screening for mobility and ensuring safe and early mobility, ensuring older adults have their personal sensory devices. So let's deep dive into each of these M's, and we're going to start with what matters. And that means we're knowing and aligning care with each older adult's specific health outcome goals and care preferences, including but not limited to end-of-life care and across settings of care. What matters is the why. Why for your patient? What really matters to you? What keeps you going? And there's this really cool trend right now in medicine, and that we're looking at what is the ikigai? This is a Japanese word, which means your will to live. What drives you to keep going? And that is so important to healthcare outcomes. And we're learning more and more about this and getting more research to show that. The what matters incorporates next of kin and caregiver information, our advanced directives, spiritual health, which we do a great job in the Adventist system, recognizing the importance of that in healthcare. Social determinants of health, which we're assessing during hospital stay, caregiver support, and community partners and aging services. And I'd just like to point out, because I see this on your whiteboards, most important thing is on the whiteboard. This is the what matters. You're already assessing this if you're filling this part out. If you're talking to your patient, what's your most important thing for today? Or what's your most important thing for this hospital stay? Now we're going to move on to mentation. And so in the mentation world, we're looking at preventing, identifying, treating, and managing dementia, depression, and delirium across healthcare settings. You might hear this from people coming in. Mom's been just a little forgetful. That's normal with aging. Well, not really. There's different levels of forgetfulness. Mentation looks at baseline cognition, which is really important to know. It looks at delirium versus dementia, cognitive impairment versus dementia, mental illness in the older adult. These are important because patients who have dementia in our care are at higher risk for complications, increased lengths of stay, and death. And quite honestly, the hospital or the emergency department is not always the best place for them to be hanging out. Let's talk a little bit about memory as we age. So normal memory, normal changes in memory, very subtle. They look more like, oh, I'm kind of having a hard time recalling something because my file box is full up here. I have 80 years of files and I've got to get back through them to pull out a name or to pull out a memory. Maybe a little slight lag in attentiveness and speed processing, or just memory issues that can happen at any age. Like, I'm overwhelmed right now. I've got too much on my plate and I just totally forgot to show up for a meeting. I do that all the time. Abnormal memory is rapidly forgetting. Like, I don't remember what I ate for breakfast and I really cannot tell you what I ate for breakfast. Difficulty navigating, especially in cars or walking or getting lost. Difficulty expressing oneself in conversation. Not remembering just to do normal things, not being able to problem solve anymore. And when these abnormal memories are paired with a need for assistance with activities of daily living, like getting dressed, needing prompting to eat, cooking, not being able to use a cell phone, that's a real good indicator that there's dementia going on. What is dementia? Well, about 10% of 65 and older adults have some form of dementia. There are lots of types of dementia. The hospital and the emergency department settings are not always the best place to diagnose it because it is looking at someone over time. But you may get a history that suggests dementia. There are different kinds. Alzheimer's is by far the most common, but vascular dementia and Parkinson's are also numbers 2 and 3. This diagnosis absolutely can be made and managed by a primary care provider. A lot of people think they need to go to a specialist to get a diagnosis of dementia, and that is not the case. And just I put in here one of my favorite resources for families and patients that you may be interacting with that has great stuff on it is alzheimers.org. They have a whole caregiver section. They have a whole section for medical providers with videos like this one that can walk you through how do I best care for someone with dementia who is in the hospital. I want to touch on delirium because this comes under mentation. So the difference between dementia and delirium is that delirium is temporary. It goes away. It comes and goes. It fluctuates. It's not permanent, but it can be characterized by confusion, anxiety, incoherent speech, and sometimes even hallucinations. There are many things that cause delirium, and this is one of my favorite mnemonics, and it spells delirium. You can see a trend here that I like it to spell out what we're talking about. The D is for drugs, 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 and dehydration. But as you can see, drugs, I mean, they above and beyond most of the time when someone is delirious, it has to do with their medications. The E is for emotion, encephalopathy, just a simple change in the environment, like not being in home, being in a new environment can really throw people and cause delirium. Low oxygen levels, which would come in with pulmonary embolism, cardiac disease, low hearing or seeing, which is not uncommon in older adults, making sure they've got what they need to hear and see. Infection for the eye, intracerebral events like stroke or METs, retention of urine or stool. I've seen many times someone be delirious because they're constipated, and you relieve that and it clears up. Another I for intake changes like malnutrition and dehydration and immobility. U for uremia, which means kidney disease and kidneys not clearing, or undertreated pain. A lot of times we think, oh, we're overtreating pain and they're delirious, but undertreated pain can cause it too. And metabolic disease, things like having a sodium level that's off. What do we do in an age-friendly healthcare system in the hospital to help people not get delirium or delirious or to recognize delirium? Well, one of the best tools we have was developed by a geriatrician who's also a researcher, and it's called the Confusion Assessment Method. It is an EPIC, and I believe that it's going to be started to be used in the ICU here if it's not already. This score shows delirium, and it looks at, number one, is there an acute onset or fluctuating course, like a change in mentation from baseline? That can be taken from the nurse and the staff or the family. Is there inattention? Is the patient easily distractible, can't focus on what's being said? Is there disorganized thinking, incoherent speech patterns, rambling, no linking in the thought process, or jumping around in topics? Or is there altered level of consciousness? And this can look like hyperactive or hypoactive, drowsy. So it can go either way, climbing out of bed or can't wake you up. If 1 and 2 are positive and you have either 3 or 4 and 3 and 4, you have a delirious patient. So what do? You take a team approach. You recognize the delirium and you plan the attack on what is causing the delirium. Again, since drugs are like the number 1, 2, and 3 cause of delirium, you look at medications and you try to identify that underlying cause. You involve family and caregivers. They're part of the care team, especially if you know someone's high risk, like they have dementia and they're coming to the hospital. Get those caregivers and families on board at the beginning as part of your care team to be helping. Be proactive. Consider implementing a hospital elder life program, which was also developed by the same physician researcher who developed the CAM. And there's a link there for you if you want to see more about that. So what does hospital elder life program do? We call it HELP. And you can use volunteers or a dedicated staff person about the same level, like a CMA or CNA, that just goes and makes rounds on patients who are high risk for delirium or who are delirious. You look at things like cognitive impairment. They come over and they update the whiteboard with the actual date. They do a lot of the things that sometimes we as nurses, not me as a nurse, sorry, y'all as nurses want to do but cannot always get to because you have a lot of responsibilities, like keeping that whiteboard up to date. Reality orientation, therapeutic activities, looking at that vision and hearing impairment. Are the devices in the room, are they working? Immobilization, doing early mobilization programs, minimizing restraining equipment like IVs, Foleys, catheters, all of that stuff. The volunteer can even bring a bike, a little hand bike. The patient doesn't even have to get out of the bed to do a hand bike. And that counts as mobilization. Looking at psychoactive medication use, so applying non-pharmacologic approaches to sleep anxiety, and restricted use of sleeping aids. Looking at dehydration and nutrition, so recognizing it early, getting volume repleted, helping with feeding, and then looking at sleep deprivation, again, noise reducing strategies. And I noticed that you have quiet hours here, which is a great program and a great start. And then sleep enhancement program. So let's talk a little bit about sleep in older adults. There is absolutely, as we age, a decrease in stage 4 sleep, which is our REM sleep. It just happens as we get older. And there's change in circadian rhythm where there's more early awakening. So the expectations that older adults are going to go to bed at 8 p.m. and sleep until 10 a.m. is very unrealistic. We're looking at more of a 6 to 7 hour window of sleep. That's pretty much what people get. And on top of that, as we get older, sometimes we keep developing more bad habits. And sleep hygiene is still important as we age. And it's the number one thing that should be addressed when we're looking at sleep before we jump to a medication. So interventions that we use for sleep are quiet hours on the floors, which you already have in place. And honestly, I was there at 2 o'clock today and it was quiet. You're doing a good job. And then looking at sleep hygiene kits and just providing information to patients about expectations with sleep. You're not going to bed and sleeping for 12 hours. That is not how we age. That's not what happens with sleep as we age. What do sleep hygiene kits look like for inpatients? Super simple. A mask, maybe some aromatherapy to put on to calm, maybe an herbal tea, earplugs, a brochure on sleep hygiene. And if you have the TV system has the music channels, pop on a calm music channel. I don't know which one yours is, but I'm sure you know. Lights off, bedtime routine, good night, blinds shut, curtains drawn, keeping it quiet, looking at things like lab draws. Do you really need to come in at 3 a.m. to do that? Could you wait until 6? So maybe shifting some of the care that happens at night so that people can sleep. All right, let's move on to medication. So if medication is necessary, we're using age-friendly medication that does not interfere with what matters to the older adult, mobility or mentation across the settings of care. And as you can see now, these 4 M's do not stand alone. They are all related. So medications, what are they taking and why? Really, what are they really taking? Like what goes in their mouth at home? And a lot of people are always defending, I've been on this medicine forever, even when it's causing side effects. So looking into that. So this is where the med rec is super important. And sometimes as I'm doing med recs in my private practice, I literally have to call the pharmacy to say, what did they pick up last and when, to figure out what the person is actually taking. We're looking at dosing with consideration of creatinine clearance and body composition. Hot topics right now in geriatrics, polypharmacy, deprescribing are big things. And I put in your handout with this talk links on there about what that means, and safer medication choices. What is polypharmacy? Well, according to the American Society of Consultant Pharmacists, people aged 65 to 69 take an average of 15 prescriptions a year, and those aged 80 to 84 take 18 prescriptions a year. So I guess polypharmacy is more than that. I mean, I think that's polypharmacy. That's a lot. We collect, and providers are more likely to add than to take away. High-risk medications for older adults. Well, I did my geriatrics fellowship at University of Virginia, and one of my favorite professors was Dr. Diane Snewstad, and she said right out the bat, any medicine can cause any side effect in any older adult at any time. And that is true. I've seen just crazy stuff happen. But The most common medications to cause problems are opiates, so pain medications, insulin, benzodiazepines like lorazepam, sleeping aids, oral hypoglycemics, which are glipizide and glyburide, antipsychotics, and anticholinergics. Today, Dr. Herbert and I were looking at a patient's chart and who's having problems walking, having problems with mentation. I said, let's pull up his medications. He was on 3 of these. This is a real thing, and it's very important to look at. Just a little about why. Why do we have more susceptibility to adverse drug reactions as we age? Number one, we have an increased fat to muscle ratio, and that affects drug metabolism. There's some drugs that stick in fat, and we have decreased water in our bodies as we age, just as a natural part of aging. And so drugs that we used to take forever might just be sticking around longer than they used to. We have decreased kidney function as a normal part of aging, so decreased creatinine clearance. Someone's creatinine can be 1, but they have low muscle mass, and that really means they're at a creatinine clearance of less than 60%, with the numbers looking normal. Decreased acuity of vision and hearing, decreased beta-adrenergic responsiveness, thinking about when we stand up, our beta receptors aren't kicking in as fast, which makes us more vulnerable to orthostatic hypotension. And then frail older adults are much more likely to have malnutrition, nutritional issues, vitamin deficiencies, and low protein levels. Protein and drugs go hand in hand. You need them to get the drugs in and out of your body. And when your albumin is low, those things are sticking around, and it really makes a difference. So when we look at medications for older adults and we start prescribing, we start low, we go slow, and we get rid of things, even if they've been on the medicine for years when they're causing adverse reactions. Okay, the last M is mobility. Mobility, ensuring that older adults move safely every day in order to maintain function and do what matters. I like to ask the question, when is the last time you fell? Because when you ask, do you fall? People just say no. They don't want to tell you that they fell, but sometimes they'll be honest and be like, oh, I fell last week, or I tripped, or I don't, So that's my question that I like to use. We like to know when people are falling. We also like to know what is causing them to fall. And one of the things that I see is frequently skipped are the orthostatic vital signs. These are just a simple set of nursing things that you can do with a blood pressure cuff. Patient laying down, sitting up, standing up if they can. Is their blood pressure dropping? And I see many patients who get discharged from the hospital without ever having this done, and they're coming into, I work post-acute care, they're coming in and they're orthostatic, and I'm adjusting medicine. So I really encourage that to be done in the hospital when possible. Getting the PT and OT involved as soon as possible, including possible consults in the emergency department. And looking at early mobilization in the hospital is very important in this category. And I see that we're already doing that in the ICU here, which is wonderful. So again, there's some normal things that happen with aging that affect our mobility. You can see this person here has a lot of loss of muscle tone. That's called sarcopenia. That just happens as we get older. Now, some people can prevent that by exercising and bodybuilding, but not everybody does that. We're Americans. I don't know what to say. There's decreased sex hormones. There's decreased vision and hearing, decreased bone density. Again, our beta receptors aren't as perky as they used to be. And we have decreased righting reflexes, which increase our sway, all making us more susceptible to falls. In hospital early mobilization, let's talk about that, because there's emerging data that shows that this really can help decrease length of stay and improve outcomes. Getting people up out of bed, even on day 1, not waiting until the day before they're leaving to do a physical therapy consult and get them walking. This is very important. It can prevent things like bed sores, pneumonias, further complications of just being immobile. This includes the ICU. I was so happy, like I said, to see this already happening there. And this is another place the Hospital Elder Life Program can play a role in early mobilization. So fall prevention, just a little bit about that. Screening patients and offering intervention before falls with injury can really start in the outpatient setting, but also can be done in the hospital setting, even if people aren't here for a fall. Consider checking those orthostatic vitals prior to discharge home and being proactive about the PT and OT. What things cause people to fall? Well, all of these things, medications, and at home, rugs, cars, getting in and out of cars is very common, pets, and toileting. These are the things that I see when people have come in for a fall. Most likely one of these things was involved. What can we do about that? Well, here's a great algorithm with screening questions. I know you can't see it on here, so I put a link. The STEADY. The STEADY is a CDC program done to help patients recognize fall risks, fall hazards, look through their house for their own fall risks. It does not have to be a professional to do this. You can send information with them. And I believe there's a smart form in Epic with screening questions about fall risk that I encourage you to look into and incorporate in your practice. So we've been around all the 4 M's, and I've given you a lot of information. I just encourage you to pick one of them and start really deep diving in your thought process as you're caring for patients about that M. What does it look like? What can you do differently? Where can you make an impact? I would be remiss talking about age-friendly healthcare without talking about caregivers or care partners. And so I would consider you as a team, a nursing team, and as a hospital system to create a care partner guide for your system, including local organizations that have resources for older adults in the community, including expectations for family members as people come into the hospital, helping them feel like they're part of the team, recognizing that they're a caregiver. It's hard. It's hard to be a caregiver, and people are tired by the time they get in for a hospital stay. Give clear expectations at the beginning and acknowledge the challenges that become with being a caregiver and offer support. Many caregivers are actually at more risk of health complications than the people they are caring for because they are skipping out on their own routine health care and prescriptions. If you're interested in learning more about geriatric nursing or how you tend to geriatric patients or older adults, you can look into the NICHE program, which is an excellent resource. It's called Nursing Improving Care for Hospital Elders. There's also the Institute for Healthcare Improvement Age-Friendly Action Communities that go on all the time. You can register a team. There's webinars. Sometimes you might even see me on there talking about my healthcare system in Hendersonville. And there's also a gerontological nursing certification. And with that, I'll just remind you that God said he's going to be our God throughout our lifetime until our hair is white with age. And that is very true. So I'm open for questions now and comments. I hope you found this helpful. I hope you can get at least one of those things or put the 4 M's right here and right here, because when you carry them with you, you can't help but doing best care for older adults. Thanks.